Trained as an oncologist, he was the founding chair of the Department of Bioethics at the Clinical Center of the National Institutes of Health. A leading authority on global health and bioethics, he served as special advisor to the Obama administration on health policy, and he maintains a blog on food. At Penn, he is Diane V.S. Levy and Robert M. Levy University Professor, with appointments in the Department of Medical Ethics and Health Policy in the Perelman School of Medicine, and in the Department of Healthcare Management in our Wharton School. He also works with me as Vice Provost for Global Initiatives. Please join me in welcoming Professor Ezekiel Emanuel.
Well, from Robert, you got beautiful poetry. From me, at best, you'll get prose, not necessarily whether incoherent sentences. You're going to go from the ethereal down to the hell of policy wonkdom. But it is a pleasure to be here in LA, after all. I do have a brother here and 3 lovely nephews, and I love this city. It's just the weather's so great, I don't know how you get any work done. Some of us have to suffer to get work done. As Vince mentioned, I am an oncologist, and I have been heavily involved in the health policy debates raging in the country over the last few years. And a large part of my research is focusing on what to do in the course of the debates, in the course as we're, over the next decade, going to be reforming our healthcare system. And so I want to set and situate the next discussion, which you're going to partake in, for you. In 2010, the last year for which we have reliable data, the United States spent $2.6 trillion on healthcare. Now, I've been to a lot of audiences. I lecture on this topic all over the world, from Oxford to Harvard to Stanford. We did Engaging Minds in New York. And the one thing I know for sure is that people have a hard time conceiving how big that number is. Now, you may have remembered at the start of the morning here, Barbara asked you this question, like, how far is the Earth to the moon? And you had to put in 90% brackets. And one of the ways I try to put this number into context is to say, if you stacked up crisp $1 bills, one on top of another, right out of the Federal Reserve, no crinkles in them, so they stack real nicely, and you put them on top of each other from the surface of the Earth, you get 70% of the way to the moon if you have $2.6 trillion worth. It's an astounding figure. Another way I put it in context is here on the slide. You think of our healthcare system, what we spend on healthcare each year is equivalent to what the French spend on everything. Cars, food, vacations, education, clothing. We spend just on healthcare. It is an astounding amount of money. And I frequently say to my students, when it comes to healthcare, we are literally on another planet compared to the rest of the world. We're just not on the same planet. So that naturally leads to the question that I'm very interested in is, what should we do about this problem? And I don't think it's just me who should be interested in it. I've argued that all 300 million Americans have a stake in this question, not just because of their health, but because of many other things they care about, whether it's the education of their kids, the federal deficit, and wages. And one way of dividing solutions to the health care cost issue is to think about these sort of buckets. We could increase productivity and efficiency. So, for example, one of the things that's happening as a result of the healthcare reform bill is more IT in terms of the billing system. Right now, we spend an incredible amount of money on the administration of the healthcare system, about $160 billion. And some of us have estimated that, in fact, one of the big problems is you have a separate bill system for WellPoint, separate from United, separate from other healthcare systems. Why isn't it kind of like swiping your Visa card? It could be that simple. And actually, it's been calculated that if you have a swipe of the Visa card and a few other things, which all arise from that, having that common electronic billing system, the healthcare system could save $30 to $40 billion a year without breaking a sweat. So that's an area of productivity and efficiency that we could have without compromising quality of care at all. And there are many others. A second thing you could do is what's called increase high-value interventions. We know, for example, that a lot of Americans are not getting care that they should get that will, in fact, improve their longevity. So to give you an example, it's estimated that at least 1 million people on Medicare who have high blood pressure haven't even had it measured, much less controlled. Plenty of people who are at risk for pneumonia have not had a vaccine for it. And we could go on and on and on. We don't do so well on things that are proven to advance health. We could do a lot to increase those high-value interventions. And there are a lot of the Affordable Care Act is going to incentivize that very activity. Now, for whatever perverse reason, I happen to be interested in the last. Not doing more, not being more efficient, but cutting things out. Maybe it's because I'm an oncologist. Anyway, I'm interested in how we might decrease low-value interventions. And I'm going to talk with you, and you're going to participate in thinking through what our policy should be to a whole series of interventions related to cancer. So I'm going to tell you a few stories and then ask you some questions, and you better have your hand on those clickers because your input is critical to this talk. Avastin and the case of metastatic breast cancer. So in 2008, Avastin, which is a drug, received accelerated FDA approval for the use in the treatment of women with metastatic breast cancer. That's women where the cancer is spread beyond the breast into the bone or the liver or the lung and is typically at that point not curable. The decision was based on studies that showed that Avastin slowed the progression of the disease. Although it did not increase overall survival, women did not live longer when they were on Avastin, and interestingly, they didn't actually have a better quality of life because it has some side effects. But it looked promising, and the FDA said, we're going to give you accelerated approval, and we're going to get some more data. Subsequent studies, which were published last year, actually in late 2010, showed that Avastin didn't improve the quality of life of patients, so they reconfirmed that data, and again, definitively proved that they didn't increase overall survival, and yet there were significant side effects. There are, however, a few women, when you give it to them, do seem to live a lot longer than you would have anticipated from the Avastin treatment. In November 2011, the FDA said, we're not covering Avastin for breast cancer. They withdrew that approval and that indication for treatment. Now, the cost of Avastin for 1 year is $88,000 per patient. Medicare, very quickly, actually, before the FDA made the final decision, there's a sort of committee that reports out, and between when that committee reported out and said FDA should withdraw the approval for Avastin, and before the final decision, Medicare intervened and said it's going to continue to pay for Avastin for metastatic breast cancer, even though the FDA is going to say they're withdrawing the marketing. Blue Shield of California, an insurer here, and Kaiser both announced that they're not going to continue to pay for Avastin. So get your clickers ready because I have a question for you. Oh, before I say that, that decision, highly controversial, and decisions about what to do, whether to cover something like Avastin or not, get wrapped up in charges of rationing. So I can tell you, every time I go to the Hill and talk to a congressman or a senator's aide about how we ought to proceed, the immediate reaction is, oh, well, we're not sure we can do that because of rationing. And this is a quote from Senator David Vitter from Louisiana. Right around the Avastin case, he said, the fact remains that thousands of women today depend on Avastin as a vital tool in their fight against breast cancer. And the FDA should not have taken the option off the table by rationing. So you can see it always gets hooked up into this. So I want to ask you, this is the question, is the decision by Blue Shield of California and Kaiser not to pay for Avastin, is that rationing? If you think it's rationing, press 1 or A on your clicker. If you don't think it's rationing, press 2 or B on your clicker. And you have these 10 seconds. I do this with my students in class all the time. They seem to like it. I hope you like it. the results. So 2/3 of you said it's not rationing, not to cover it, and 1/3 of you roughly said it is rationing. This is a common phenomena that we see when I ask this question. It does get to the deeper question, and I'm just going to highlight this question for a second. What actually is rationing? Now, we've created this grid to look at a series of different interventions. So if you look across the top, one possibility is you have a high-cost intervention that has no benefit over standard treatment. That's the Avastin case. Is not paying for that rationing or not? The second is, what about a high-cost treatment that adds convenience or reduces side effects? Is that rationing or not? I'm not going to answer that. We're going to think about it. What about a higher-cost treatment that has small additional benefits in terms of survival? And what about a higher-cost treatment that has large additional survival benefits? So you might say this is the spectrum of cancer treatments, and we're going to ask you over the course of time, through a bunch of cases which are all real, what you're thinking. So the next one is one I've written about. It's proton beam therapy for prostate cancer. So we dealt with the women in the group on the breast cancer. Now we're going right to the men, and we'll keep on the men for a while. They can take it. Proton beam therapy is a type of radiation used to treat cancer. You generate proton beams, however, requires this huge machine called a cyclotron, and you have to encase it in a football-sized building with a lot of lead and a lot of concrete. The advantage, theoretically, of protons is that they can be focused more precisely to where the cancer is, minimizing the damage to surrounding healthy tissue. Now, proton beam therapy has been demonstrated to be beneficial in cancers of the brain and the spinal cord for children. So we definitely know in that case, where they're close to the surface and you've got a lot of very valuable healthy tissue around that, brain cells, proton beams are very valuable. Fortunately, there are not a lot of cases of pediatric brain cancers in the world. Only 3,000 in the United States. Only 3,000 in the United States per year. So it's a pretty lucky. Now, it's impossible to pay for the proton beam facilities capital costs around the country with just 3,000 machines, 3,000 patients. The consequence is that places that have proton beams are looking for other cancers which they can use the proton beams on. They've tried breast cancer, they've tried lung cancer, esophageal cancer, liver cancer, and the place they've landed on is prostate cancer, in part because there are 250,000 men a year who get prostate cancer. They tend to be older, and one of the things we know about older men is they tend to be more wealthy. And so they're targeting this group. I don't think, I've been a little cynical there. Just a little. Currently, there are 9 proton beam facilities in the United States. In fact, there's one at the University of Pennsylvania, one at the Mass General, one here in Southern California in Loma Linda. But there are 20 more in various stages of planning and development. Not all of them are going to actually be built, but many of them will. About a year ago, Mayo Clinic announced that it's going to build 2 proton beam facilities. It's not satisfied with one. It's going to have 2 at $180 million each, and one in Rochester and one in Scottsdale, Arizona. And they just broke ground at the end of last year. Here's the rub. Proton beam therapy has not been directly compared to any of the standard treatments for prostate cancer. There is simply no data showing that it's better or even equal to standard treatment, whether it's standard radiation, surgery, or just observation. Currently, Medicare pays $59,000 for proton beam therapy and $26,000 for the standard radiation treatment used if you don't get proton beam therapy. So here's your next question. Get the clickers out. Ready? Do you agree or disagree with Medicare's decision to pay for proton beam therapy for prostate cancer? Press A or 1 if you agree with Medicare's decision to pay $59,000. Press 2 or B if you disagree with that decision. And C if you're confused. You got 10 seconds. All right. The answer? 66% of you disagree with Medicare's decision to pay for it, which means you think Medicare should not pay for it, and 17% agree, and 17% are confused. So it's the same two-thirds, roughly, that don't think we should have paid for it. Next question. If Medicare agrees with you and says, we're not paying for proton beam therapy again, would that be a case of rationing? Again, A, if you agree, B, if you disagree, and C, if you're not sure. You guys seem to be quick at answering here, so maybe we can reduce it from 10 to like 5. Most of you disagree. You think it would not be rationing if Medicare decided not to pay for proton beam therapy. So one of the things I wanted to point out to you is that in these cases, except for one, there's been a pretty consistent view here, whether it's not proven in the case of proton beam, it's proven not to be advantageous in the case of Avastin, whether you give it and there's only a few months extra in the case of Provenge, or in the case of Abraxane, you get convenience and fewer side effects. Most of you thought that if we didn't pay for that, that wouldn't be a case of rationing and it would be okay to do. Not all of you. Pretty consistently, except for that one case, two-thirds of you thought that would not be rationing. Now, those are cases of low-value treatment. In some cases of no-value treatment. The Avastin's no value. The proton beam at the moment has certainly not proven to be of value. It's exactly those cases where we have tens and hundreds of billions of dollars tied up in the American healthcare system, and every time we try to approach discussing it, the politicians certainly get nervous about rationing. One of the reasons I'm trying to do this research and to do it on a slightly more scientific basis, although you're a very good crowd, you respond well, is the fact that we don't know what the American public thinks is rationing. And we don't know which cases they actually think are rationing and which case they think is perfectly fine not to have the government pay for it or to have the government pay what it paid for a comparative treatment and allow patients to pay extra. So what we're going to do, and the research projects we've launched is, we're actually going to be interviewing, in cases like this and many other cases, not just the general public like yourself. We're also going to discuss this issue with cancer patients to find out what their experience and understanding of it is, and with oncologists who treat cancer patients from all over the country. We have some preliminary hypotheses that, in fact, while people say, well, it'll be different, cancer patients won't agree, at least initially, and we don't have survey data, what we have are focus groups, that doesn't seem to be the case. And in a lot of other previous examples, what people think patients are going to do and why they're different from the public, we've seen that patients really respond just like the public. And the fact that they have a disease doesn't seem to change them. So that's going to be our research project. I think this has the potential to dramatically change the attitudes. Again, a piece of data doesn't change anything, but it leads to a very significant change in the way people can begin discussing it. The charge, what we're hoping to do, is to take away the charge of rationing and to begin to think more clearly about what we want to pay for in terms of medical care and what we think either we should leave to the patients or we just shouldn't pay for as a society. That is obviously going to be the critical question going forward if we want to control costs in the American healthcare system. Thank you very much.